Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. We've got your free 31-page PDF on the top 200 drugs. That is absolutely free to use. Simply an email will get you access to that. Also, with your email subscription, we'll get you updates when we've got new podcasts and other content available as well. So definitely a no-brainer to snag that. Simply an email is all it will cost you at reallifepharmacology.com. All right, drug of the day today is Airsupra. That is the brand name. This is a relatively newer medication that has come out, and it is a combination of a beta agonist, more specifically a short-acting beta agonist in albuterol, and an inhaled corticosteroid. So that inhaled corticosteroid is budesonide. So combo of albuterol and budesonide. So the budesonide piece of this is anti-inflammatory. Again, it's an inhaled corticosteroid. It reduces that airway inflammation that is prominent in asthma, which is what we're going to use this medication for in most cases. The albuterol is the short-acting beta agonist, and specifically, it's an agonist at beta-2 receptors. So this is going to cause bronchodilation, basically that airway to open up, and help patients who are having an asthma exacerbation breathe a little bit better. So this combo allows for use of a rescue inhaler, a short-acting beta agonist that's going to help patients breathe really, really quickly. Should help with that in the short term. And it also combines the anti-inflammatory effect of the inhaled corticosteroid. And this has been a shift over the last 5+ years now, at least, towards getting inhaled corticosteroids into patients while they're having that asthma exacerbation and trying to really slow that inflammatory process down in addition to opening up the airway. So historically, it was just beta agonist therapy, but now more and more research is showing, and some of the guidelines are obviously leaning that way now too, where we want to get that inhaled corticosteroid going as well, in addition to having a medication that can open up the airways quickly too. So that's where this medication can be used, is in acute relief of asthma symptoms there. So that's the primary indication. As needed, PRN rescue therapy in asthma obviously helps reduce those symptoms. And then the inhaled corticosteroid, obviously over kind of the longer term, minutes to hours, that's going to help reduce that inflammation and prevent a future attack, or help reduce the risk of a future attack as well. It is the first FDA-approved rescue inhaler combining a short-acting beta agonist with an inhaled corticosteroid. Recall that we have Symbicort, which is one of the ones mentioned in the GINA recommendations, for example. That has formoterol and budesonide, which formoterol is a long-acting beta agonist. So a little bit of differentiation there. In that this has the short-acting beta agonist instead of a longer-acting beta agonist. All right, so it is a metered dose inhaler. Again, albuterol, budesonide combination. Typical dosing is 2 inhalations as needed for asthma symptoms. And this can be used up to a max of 12 inhalations in 24 hours, or 6 doses if you're giving 2 inhalations at a time. With the inhaler, priming does need to be done. So before first use, prime the inhaler by releasing 4 test sprays. And if it has not been used for over 7 days, it's recommended to do 2 test sprays, just to make sure that that device is working well and the patient is actually getting the dose. So now in asthma care, hopefully we're going greater than 7 days without having to use our acute relief inhaler. So that is something that would definitely be good to educate your patients about. Adverse effect profile, usually it's like cough, throat irritation, maybe a hoarse voice, those type of things that can definitely happen with inhalers in general. With the inhaled corticosteroid component, you got to remember the risk for fungal infection like thrush in the mouth area. So be sure we're doing some rinsing and things after using that medication, of course. With the beta agonist component, if you get enough systemic absorption or if you're using it in a combo with other medications that maybe worsen this or amp a patient up, you can get a little bit of shakiness or potentially an increase in that heart rate and palpitations, those type of things. Rarely you may see hypersensitivity type reaction and things of that nature. All right, so patients we want to pay attention to, those with probably more moderate to severe cardiovascular disease, particularly those that, maybe have a higher blood pressure as well as tachycardia. That beta agonist could exacerbate that a little bit. Risk of adrenal suppression, so patients may be already taking systemic corticosteroids, and we add to that corticosteroid load. Not something crazy worry about, but in patients that are at risk for that or something, that might be something to pay attention to. And then that candidiasis risk, remember to rinse the mouth after using this medication. That's definitely an important thing to do. As far as kind of monitoring this medication, obviously we're looking to alleviate those symptoms from that acute asthma exacerbation. So that's going to be important. Paying attention to how often patients have asthma exacerbations, that's going to help us guide therapy. Definitely something you want to do. Obviously how often they're using the inhaler along with that. And the severity and frequency of exacerbations. So did they have to go to the hospital, for example? That's a really, really good thing to monitor. And obviously the more and more those negative things happen, the more and more likely we need to escalate chronic therapy and maintenance therapy for asthma. So definitely pay attention to those things for sure. From a pharmacokinetic standpoint, absorption isn't a ton. Systemic absorption through the lungs isn't a ton. Not something I worry about too much in somebody that has an asthma exacerbation, let's say once every 3, 4, 5 weeks or something, and they're using this once or twice during that exacerbation. Systemic exposure is probably not a big deal. Okay. So, but with that said, budesonide does have a pretty high first-pass metabolism if any of that medication is kind of inadvertently or accidentally swallowed a little bit. And it is metabolized by CYP3A4. So, again, systemic absorption, very, very low overall, but something to look out for, particularly if you've got a patient that's taking a lot of it or maybe they're taking other corticosteroids frequently for another reason as well. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, NAPLEX, BCGP, BCMTMS, go check out meded101.com/store. We've got tons of resources there that have helped thousands of pharmacists pass their board exam, and they'll absolutely help you as well. So go check that out, meded101.com/store. In addition, if you're a nurse, dietitian, pharmacy technician, med student, we've got tons of other books and resources on pharmacology. So don't hesitate. Go to meded101.com/store. All your purchases there go directly to help support this podcast. So go get yourself a friend, a resource, or yourself, and help support this podcast. Again, all those resources, meded101.com/store. All right, wrapping up with drug interactions. I alluded to budesonide being broken down by CYP3A4. So CYP3A4 inhibitors could potentially increase that systemic concentration. And then likewise, CYP3A4 inducers could lower systemic concentrations of budesonide. With the beta agonist piece, the albuterol, I think of medications, drugs that have additive type effects. So beta agonists can cause some tachycardia, so I think of drugs that have stimulant type effects. So I think of a medication like modafinil, which can be used for something like narcolepsy. I think of stimulants for ADHD, your methylphenidates and things like that. Caffeine. So if you got a patient that has high caffeine intake, maybe inappropriately high caffeine intake, that can cause tachycardia. We add albuterol on top of that frequently. We could potentially exacerbate those issues there. With the albuterol, again, you got that beta agonist action. You got to remember the flip side. So beta blockers, particularly non-selective beta blockers, so that's a medication like propranolol, could potentially antagonize or reduce the effects that albuterol has on treating an asthma exacerbation. So again, something to think about there. All right, well, I think that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor, leave a rating review on iTunes or wherever you're listening. I greatly appreciate that. Share us with friends, colleagues, classmates, anybody who could benefit from some pharmacology education. If you want to reach out to me, mededucation101@gmail.com, or you can track me down and connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. I would greatly appreciate it if you'd support the sponsor, meded101.com/store. And of course, I hope you have a great rest of your day.